I bring you greetings from the city of the Taj Mahal. It is a great pleasure for me to be with you this morning to represent SARC, an organization which joins the ignited minds from South Asia to address the common problems which confront the urologists of the South Asian region, and we are trying to find a common solution to these common problems. And one of the common problems here is stone disease, urolithiasis, which we all know is one of the most prevalent disorders in endourology that we have to handle. And the incidence is widespread across South Asia. So it is not uncommon for in a busy endourology practice to find such cases on a day-to-day basis. And we also know that among all the available modalities, PCNL is probably best suited for managing these cases, despite the fact that it carries a relatively higher morbidity. It also has the best and the highest success rate in terms of stone-free rates. So the latest guidelines from all international agencies have also now acknowledged PNL or PCNL as the first choice for management of staghorn stones, as you are all aware. However, we in our Indian subcontinent had always known this, that PCNL monotherapy is the best choice, even at a time when sandwich therapy used to be the go word for staghorn stones. So all you need is a bit of perseverance and a little bit of hard work to really go after these stones, and you could achieve complete clearance in many of these cases in 1 or 2 sittings. And it was only this procedure, PCNL, which can give results like this, which are gratifying not only to the surgeon, but also to the patient in the long run. And I'm sure many people in our audience would have experience with such cases and with such results. However, we all understand that staghorn stones do pose a significant challenge, and not only in technical terms, but also in terms of the patient's expectations, the human factor, which are also multiple. But above all, the difficulty is that, as you all understand, a stone to a patient is just a stone. Very difficult to make them understand the importance of the difference between a staghorn and an ordinary single stone, and the question of the costs, which is a big bugbear in our subcontinent. I'll just present a very short case as an example. A 55-year-old lady who presented to us with fever, anemia, uremia, frank urosepsis, bilateral stones, and pyonephrosis. And first step was percutaneous nephrostomy, followed by plan for PCNL 1 by 1. So we opted for the other side first, and she was then taken up. One of the teachings from our teacher and mentor to many of us, Dr. Mahesh Desai, has been to put all the guide wires that you need right in the beginning and then start working with one at a time. So this is what I do: put all the guide wires in place and then start fragmenting the stone make one track and then start clearing the stone. And once you've done with one, then make the second track and then start clearing the stone with the second track. And with a bit of perseverance, as I said earlier, and a little bit of diligence and hard work, it is not difficult to clear these stones with 2 or at the most 3 tracks, and with mostly 1 or sometimes 2 sittings. So, and earlier we used to transfuse a lot, but nowadays the need for blood transfusion has also gone down significantly. And you can achieve complete clearance in the vast majority of cases. And the end point is always trying to achieve complete clearance. And this is the post-operative result on the left side. And she subsequently underwent PCNL on the other side after 2 weeks. And on the right-hand side, you can see the final result. And the serum creatinine also ultimately stabilized at 1.8%. So, to achieve good results in staghorn stone, one requires good access with an ultrasound guidance as far as possible, if it is available, use of additional tricks like use of flexible nephroscopy and mini perks, if you can, and some new technology like the new intracorporeal devices, and most of all, as I said, good amount of motivation. So the most important thing about PCNL, as we all know, is accurate access. And the reason why access in PCNL is challenging comes from the age-old fish eye story of Arjun from Mahabharata. Some of you may be aware of it. And the trick here is you are hitting the target somewhere else while you are looking somewhere else. And that is the biggest challenge in PCNL. The other problem is the high vascularity of the kidney, and the challenge is to make your puncture without damaging the blood vessels. So the best approach is to go into the least vascular plane between the vascular territories of the anterior and posterior division of the renal artery into the papilla of the posterior calyx. So you require to have a good understanding of the renal vascular architecture as well as its relationship with the pelvic calyceal anatomy. And to this end, Sempio served us a great deal by a good study of the renal anatomy, showing that if you make your puncture through the papilla, then you will avoid injuring the interlobar vessels and make a bloodless entry. Now, to this end, ultrasound helps us a great deal. And if you have facility of ultrasound, in addition to fluoroscopy, of course, then you can make your puncture more accurately with less blood loss, less trauma, and of course, most importantly, less radiation exposure to yourself and to your patient. And in a busy urology practice, this becomes very important. And there are multiple studies, including one from our center, which showed that the ultrasound-guided puncture achieves all of this and more. And there are more and more centers across the world which are now using ultrasound for puncture guidance, always in addition to fluoroscopy, I may add. Similarly, use of flexible nephroscope, whenever available and possible, reduces the need for multiple tracks and reduces the risk of bleeding and radiation exposure significantly. Another major advance in PCNL which has come about is the use of minimal access, miniaturization using smaller tracts, smaller nephroscopes, and this reduces injury to the parenchyma and most importantly, the risk of bleeding. And I think this is the single most important contribution to percutaneous technology in the recent years. And in our experience, all small and medium volume stones are done now by mini PCNL, and in large complex staghorns, all secondary tracks are now done by mini PCNL. So the primary large bulk is removed using a standard track, whereas all the secondary tracks are mini percs nowadays. Next, the use of newer technology. Now, for many years, after the initial use of ultrasonic, the pneumatic lithotripsy has been the mainstay of stone fragmentation in PCNL. But in recent years, we have had more choices and use of laser, and the newest dual energy sources have come in with great advantages. Now, as we all know, lasers, the holmium laser especially, has been a great help, especially in developing miniaturization, and for mini and ultra mini PCNL, this has been a great boon. Also for flexible instrumentation, because you can't use any other energy for flexibles. In addition, for the rigid instruments and especially for staghorn stones, we have found these dual energy stone fragmentation devices very useful. The first one to come was the Lithoplast Master from EMS, but these newer ones like the Olympus Shock Pulse is something which we have found extremely useful in clearing large volume stones very quickly and reducing the duration of surgery and improving the results tremendously in the recent days. And this combines ultrasonic and ballistic or pneumatic energy together in fragmenting large and hard stones and clearing up the stones very fast. And the advantage is that there is a single probe, and it delivers both pneumatic and ultrasonic energy together. There is a newer version from EMS, which is sold by Boston Scientific, called the EMS Trilogy, which is very popular in the West. It's still not available in our country, and I think in our subcontinent either, because everything in this machine is disposable and the cost is a consideration. However, both these systems work on the same principle of combining ultrasonic and ballistic energy with suction. And the advantages are that they work for both standard and mini PCNL, and they very efficiently, as I said, reduce the operating time and work very efficiently in large staghorn stones. In cases of staghorn stones, when you require multiple tracks, thankfully now you don't require to put multiple tubes, because we have understood that just one drain tube or even a tubeless PCNL is sufficient, and this reduces the post-operative morbidity and pain significantly. So you can just do away with these multiple tubes, and a single tube is sufficient. A lot of these patients are uremic, and across the spectrum, most of these patients will improve after surgery. And this is one last example of a staghorn stone in a solitary kidney, as you can see on the preoperative IVP. And this is the postoperative X-ray after 2 sittings, and a follow-up intravenous urogram, where you can see complete good recovery several months later. And this patient was done almost 2 decades ago and continues to be in the follow-up in good health. So for large, complex staghorn stones with good application and some tricks, you can go on taking care of these unfortunate patients and do well in your endourology practice. So thank you very much for this opportunity. Thank you.